Thank you. Thank you for, I'll probably just hold this if that works. Welcome everyone. Every moment I go over is keeping you from lunch. I'm aware of that. I will try to be quick. And really, I have no conflicts of interest. I'm talking about patients, but I've modified details. If I talk about childhood TB, I'm talking about tuberculosis in those under 15, pediatric TB, those which pediatricians look after up to the age of 17. And I think most people in the audience, it's always worth remembering that we talk about TB infection and TB disease as distinct entities. By TB disease, we mean we can find evidence of organ involvement, either clinically or by an abnormal X-ray or by actually getting a positive culture for Mycobacterium tuberculosis. But that group of people with TB disease is derived from a much larger group of people who are latently infected, and we diagnose infection based on the absence of evidence of organ involvement, that is, normal X-rays, well-looking child, but with either a positive tuberculin skin test or interferon gamma release assay. It's worth stressing at this point, because this is a talk about clinical TB disease, a relatively rare event, that 10 to 30% of people with TB disease have negative skin tests or interferon gamma release assays, and not thinking about TB because the TST is negative is one of the pitfalls in diagnosing TB. So I'm very briefly going to talk about global epidemiology, Canadian epidemiology, and then features in adolescence, and it's the clinical features that I was asked to stress. Some of my life is in consulting general and infectious disease pediatrics in Ajax, 2/3. So I'm aware how easy it is to miss things in a general kind of climate, especially things that are not common. And I think it's worth just putting out pointers there. It's very easy to sit at sick kids and say, dear, how did they miss that? I know it's not so easy. So let's go through patient X, because patient X is the kind of patient that I think should be easier to identify and who is still unfortunately missed. This is a 16-year-old who has a cough for 4 to 5 weeks. He has weight loss. He has 3 physician visits. He begins with some amoxicillin. There are 2 X-rays, both of which note upper lobe disease. And if you take one thing home, upper lobe disease in an adolescent or adult, in my view, with the right epidemiology, is TB until you prove it otherwise. And sometimes it's very easy to prove it. The amoxicillin has no effect, and then he gets a respiratory fluoroquinolone, in that case moxifloxacin. It could have been levofloxacin. Again, I would stress this is actually a very valuable drug in the context of drug-resistant TB fluoroquinolones. You may burn that fluoroquinolone by using it in someone with TB that might have been drug-resistant to start with and might give that patient a death sentence, or at least a horrible sentence. So if you really think it's TB, you need to get something, and the simplest thing to get, I'll say it throughout this talk, is a sputum. Often an expectorated sputum sent with a public health requisition form for culture, TB culture and sensitivity will give you the diagnosis and save a lot of time and trouble and save that child exposing the school and his classroom for another 6 weeks. So we're talking now about this is typical TB. It's TB in the lungs, it's got cavities sometimes. There are typical symptoms: fever, cough, night sweats, weight loss, and hemoptysis. If you're looking for all of those, you're being greedy. We find that hemoptysis always generates a quick response, but the others don't so much. It's multibacillary. Sputum's easy to obtain often from the adolescent. They can cough, you can get it in the sputum jar. Smears and cultures convert to negative. It's in the world, the overall rate is about 132 per 100,000 per year. Canada, by contrast, 4.8, 4.9 per 100,000, but there are pockets of Canada. Nunavut right now, 148 per 100,000. It's a terrible shame of Canada. When we look down to the next slide, and it's important because these are countries from which we in Toronto derive our strength and our vitality through new immigration. And if you look in Toronto, firstly in Ontario, the overall rate's still about 4.8. Peel and Toronto have rates about 9.7, about double that. And here's a scatter map from 2012. Is it there? No. Scatter map from 2012. The distribution's now changed. There are more cases in York region. There are now more cases in Durham region. But certainly Scarborough and the East End has its reasonable number of cases of TB. What about pediatric TB or childhood TB in Canada? Firstly, overall, we just completed a survey through the CPSP surveillance. A horrible statistic is most childhood TB is in Indigenous Canadians with very high rates, especially in the Inuit, but especially on First Nations on reserves. For the Greater Toronto area, it's very different. It's either a disease of foreign-born children who may have come to Canada latently infected and activate TB, or may travel back to the high-burden country and get re-exposed, and that is actually, we're discovering, an important thing, or in the children of foreign-born parents, and those children of foreign-born parents are acquiring TB either within the extended family in Canada or via travel. So I'm going to show you other cases just to reinforce this message, because here's another case who had 3 emergency department visits, ongoing cough, multiple antibiotics, and it wasn't until there was hemoptysis that someone actually thought of the disease. Sputum, once it was taken, and that was a spontaneous sputum. The patient's given a jar, told to go home. You probably don't want them coughing more in your office. Told to go home, first thing in the morning, turn on the shower, cough into the specimen jar, or go outside and do it in the open air. And really, you can get a diagnosis. We've had a couple of recent cases where physicians not trained in Canada immediately did that with their patients and came to diagnoses very quickly. And I show both of these because I keep emphasizing upper lobe disease in adolescents. This is someone with lower lobe disease. Someone who trained me in Southern Africa said, you're looking for upper lobe disease, you're being greedy. Airspace disease in the right epidemiologic context, remember, either foreign-born or the child of foreign-born, can be TB until proven otherwise. More examples of upper lobe. So if you see your report, you don't see the films. It's always great to see the films. This lacy reticular nodular one on this side is another example. Pleural disease often is an isolated pleural effusion, and generally we want to... this child had all kinds of clues, including upper lobe airspace disease, and was still treated as a paraneumonic effusion. For those in hospital practice, a lymphocyte-predominant pleural effusion in my context is TB until proven otherwise. So we've just reviewed patients who've wandered around sick kids' emerge rooms, making up to 6 visits before the diagnosis, range of 2 to 10 visits to all healthcare facilities. Now, a few interesting points. The mean body mass index was 50% around. Most of these aren't thin-waisted people. One guy was really buff and working out, and I think that delayed his diagnosis. People looked at him and said, you can't have TB. 30% were obese. Most had upper lobe disease. Most had chronic symptoms, and that's really important. Cough for more than 2 weeks, fever for more than 2 weeks, that's when you start really thinking. If it looks like an acute pneumonia with 2 days of pneumonia, it probably is a pneumonia. Once you're getting to those kinds of levels, and all had epidemiology. Now, clearly many of us, I'm foreign-born from a high-burden country, many of us have that epidemiology, but at least all had foreign-born. And failure to send sputum really delayed diagnosis. So if I can leave one message there. So pulmonary disease in the older child may present as an unresolving pneumonia, as a pleural effusion with or without parenchyma, upper lobe airways disease, any airway disease, and take the sputum. Induced sputum is definitely better. If you have an RT and a negative pressure room and can give them saline and get an induced sputum, you're much more likely to get a diagnosis quicker. But of course, TB in adolescence is more than pulmonary. So here's someone who presented with a synovitis of the arm, saw a rheumatologist, ended up with an X-ray because there was a positive skin test, and ended up having TB, and the synovitis was a TB-related synovitis. Here's someone with abdominal pain, weight loss, fever, and a thickened terminal ileum. in my hospital, at sick kids, that would be Crohn's, and Crohn's, but she had hypoechogenic nodes, and her ileal stricture is from tuberculosis. Here's someone with headache and visual disturbance who had a tuberculoma. Here's someone, the other patient has the characteristic leptomeningeal arachnoiditis basilar of TB meningitis. This kid was thought to have a Ewing sarcoma. This is TB lymphadenitis with discoloration, and that's vertebral involvement. And I show these not because they're weird, but in fact, when we looked in a population-based study, our adolescents often have extrapulmonary involvement. So TB in adolescents is a late diagnosis. We showed in a series some years ago. Lack of clinical suspicion was the big thing. Median of 5.5 months to get the diagnosis, and not for want of seeing physician after physician. But this isn't a low prevalence area where we stop thinking about TB. It's protein with extrapulmonary disease, and usually in recent immigrants. So missed opportunities for making the diagnosis: failure to consider the epidemiologic history, remember foreign-born children, failure to obtain sputum for TB culture, failure to send biopsy specimens. If it's thrown into formalin without a culture, we're going to delay diagnosis. Not considering TB because the TST is negative has been a catch, and expecting pulmonary disease. We've gone through some of these others. I want to just quickly focus on young children, because young children don't give people TB with very rare exceptions. They are the recipients of TB. If you find a young child with TB, that is a sentinel event. It says there's transmission in the community, or there is transmission via perhaps travel. And in fact, one child in Canada who's declaring themselves at 6 months or a year with TB is a failure. It's a failure of the public health infrastructure. And thankfully in Toronto, we have a fabulous public health infrastructure that's keeping us from seeing these. I've seen enough in Africa not to want to see childhood TB again. And by getting the, can you hear me? By getting the patients, the exposed kids quickly really helps. The current threats of cuts to the public health infrastructure really, I've told our trainees we're probably still going to be in the TB business. I'd like to be out of it. But cut public health, we were going to be there. So for those who wish to advocate in my field, that's important. So, so this kid was actually nosocomially exposed at sick kids nursery. We can go in and presented with life-threatening Miliary Tb, and is the biggest illustration to me of what happens to very young children. They're immune very vulnerable because of the pre-primary immune response. Within 2.5 months, this child had life-threatening Miliary Tb. Young children are very high risk for this and for TB meningitis. If infected under a year, the rates are 10 to 30% of these severe forms of TB. We need to get these young children quickly. We need to see them once they're exposed and prevent this from happening. And that's a lot of what we do in clinic. That kid now he's going to obesity clinic maybe. He's 15, he's fine. But his risk, he's immunocompetent. His risk was his age. That was all. And really, in the world, many of the kids we see, here's that child with his, this is a child, typical children I'd seen in Africa, breastfed with malnutrition, very rare where I worked. Post-mortem true cut biopsy of the liver said Miliary Tb. That child would have been called malnourished if statistics were being collected. TB meningitis is a very feared thing. I've not seen a kid come back intact, even if we start treatment early. And this child who has peritoneal seeding was actually a known contact, but the people in the apartment did not disclose that they were running a daycare to public health when, and he presented. Thankfully, he did well. So the younger the child, the more we quickly want to see them in our clinic or elsewhere and get them on treatment, even if they are not, if they're negative skin tests and negative x-rays, we get them on latent infection treatment until we prove they're not infected by another skin test 8 to 10 weeks after exposure. Childhood TB in Canada is thankfully uncommon, but is a sentinel event. Hilar lymphadenopathy is the hallmark in the older child, usually without complication. I show this because it's exceptional. People get worried about upper lobe disease in young children. That's actually uncommon with TB. It can be anywhere. This child happens to have gone from there to there, and the reason he's gone from there to there is that node group has now eroded into his upper lobe bronchus and caused obstruction, so he's lost volume. But that rarely happens with childhood TB. So my take-home points in a very quick talk, for epidemiology, think about, for adolescents, think about epidemiology. Do they have upper lobe involvement? Do they have prolonged symptoms? Send a sputum, try and get an induced sputum, get them referred. They may have extrapulmonary disease. And young children are at risk for severe forms of TB. I was going to maybe mention interferon gamma release assays versus TSTs. They are now available through both Life Labs and for a child who has had BCG, who you are screening, and I can talk about this after this talk while you eat, in my book, the IGRAs, the quantiferon is the one available here, are much better because of much better specificity in the context of the BCG immunized child. I'll leave it at that and take any questions.